Good afternoon, everyone, and thank you very much for joining this afternoon session. It's been a really fantastic start to the ISPNO. I hope you're enjoying the hospitality of our colleagues here in Sydney and the session today. Thanks for having a lunch and spending the next 45 minutes to discuss NF1. My name's Jim Whittle. I'm an adult neuro-oncologist. I also see AYA patients at the Peter MacCallum Cancer Centre, and also want to introduce Associate Professor Whittle Metrock from UAB, a paediatric neuro-oncologist, and to thank and acknowledge the support from Peerview as well as Springbeck's for the educational grant for today's symposium. There's some extra information there, but really what I want to bring your attention to those in the room and to those who are also joining us online remotely. Please use the QR code to interact with today's session. That's whether you want to submit questions, to engage with the polling that will come up soon. And there is the opportunity to win a prize, so to incentivise your interactivity. So I'll discourage people from coming up to the microphone for questions because that will help the engagement to those who are online as well. Okay, if you would like these slides, so today's an educational session, so we want all of the content to be made available. You can access via the QR code or come and see the Peerview team after today's session. So this afternoon we're talking about neurofibromatosis type 1, which I think most of you in the room appreciate. This is one of the most common predisposition syndromes that we see in neuro-oncology. This has a global incidence of approximately 1 in every 3,000 children born with this condition, and affects all races, ethnicities and sexes equally. The key driver of this is the pathogenic variant in neurofibromin 1, which leads to downstream activation of the RAS-MAP kinase pathway, which is the rationale for why inhibiting these tumours that we're talking about today with MEK inhibitors has clinical benefit. And what we would like to hopefully get across today is the importance that whilst we are principally talking about plexiform neurofibromas associated with NF1, this is a multi-system disease which requires a broad multidisciplinary team and longitudinal monitoring rather than just episodic care. So plexiform neurofibromas are one of the biggest challenges in looking after patients with NF1 and has associated substantial morbidity for patients. We estimate these occur at about 50% of patients and can occur anywhere in the body along the nerves. This typically grow more rapidly during childhood and can actually be life-threatening. And often we think about the associated pain and discomfort as being the critical problem associated with the experience for patients with plexiform neurofibromas. But to remember, they can also have impact on swelling, disfigurement, the cosmetic impact, and the associated emotional and psychosocial impact of these is also substantial and something that we need to consider when we're providing care for this patient group. The cartoon on the left was also, I think, important to illustrate the long-term surveillance that is needed for patients right across the paediatric, AYA and adult spectrum, and that the associated complications and different diseases that are associated with NF1 occur predictably across the lifespan. And that's important when we're devising long-term surveillance protocols for this patient group. And of course, the other thing that we're really worried about with plexiform neurofibromas, both as clinicians but also particularly patients and their families, is the risk of malignant transformation through to malignant plexiform neurofibroma, or MPNST. And again, studies would suggest this occurs in around 10% of patients over a lifetime risk, and that occurs through a sequential biological progression through to this newer condition referred to as atypical neurofibromatous neoplasm of uncertain biological potential, which is a bit of a mouthful, ANNUBP, through to subsequent genetic alterations which lead to malignant transformation into an MPNST. And so this sort of predictable genetic changes which occur from the benign lesion to the atypical lesion through to the malignant lesion is something we're trying to better understand and where there is opportunities for therapeutic intervention. But I think the critical message that we wanted to get across today from a clinical perspective is thinking about the red flags for MPNST and malignant transformation. And so educating both our clinicians and our collaborators, but also patients for red flags, including experiencing of new or worsening pain, rapid growth of tumours, as well as neurological changes. And typically this will lead to prompt us to investigate further with the use of FDG PET to look for uptake, and particularly looking for heterogeneous uptake, which can help determine biopsy and plans to select the best target for biopsy and sampling of these tumours. And I think what's really critical for these tumours is that it requires multidisciplinary consideration, and particularly around planning for aggressive surgical intervention where that can be appropriate and feasible in patients. And so just with that way of background, what we hope today you will focus on the next 40 minutes or so is to discuss the evidence that is supporting the role for MEK inhibition in both paediatric and adult patients with NF1-associated plexiform neurofibromas, to think about some of the factors that come into treatment decision-making about when to start, when to stop, how to monitor patients, and then to spend a little bit of time to think about how cross-disciplinary, multidisciplinary care is really critical for proactive management and surveillance in helping us get the best outcome for managing toxicity associated with treatment and leading to the best long-term adherence and outcome for patients. So with that, and I appreciate many people who are here in the room are enjoying your lunch, and so it may be difficult to access your phone, but if you are in the room and if you can access your device and participate in the polling for today, would be really grateful for you to join in. And just to start with this question about, well, what in your practice is the most challenging aspect of managing persons with NF1-associated plexiform neurofibromas? And you can select all that is apply here. And whilst you're going through that, we're listening to the music. Thank you for enjoying that. I don't know, Katie, I think when we were planning the session, we thought you need a 6, all of the above here, right? I think is probably the critical message. All right. Okay, so I think that's really nice in terms of how this is emerging, because we will be touching on all of these key points in today's session, and hopefully, if I don't talk for too long, we'll have an opportunity for questions later on and an interaction with the group as well. Okay. Next question. In your practice, what is the biggest challenge you face when managing a child with NF1 associated with plexiform neurofibromas? Here you have to pick one answer, so you can't click all of the above here. So really interested from the audience to see how you approach this problem and where you see some of the challenges in your clinical practice as well. All right, let's see where we go. Okay. I think what I'm really pleased to see about here, I think, is a discussion, particularly for those who haven't left the room and coming on a focus of equity and access to care. We're reminded that we're meeting as an international audience where reimbursement and access to different medications varies across countries, across age groups, and I think as an organisation and as a group, that's something that we can really work for and advocate, and access to care. Okay, and also helping us set our scene for later conversations around managing of care delivery with patients with MEK inhibitor therapy. What do you find is the most challenging part of clinical practice? And again, have to select one rather than selecting all of the options here. Okay, all right. Okay, coming through, but we're seeing some, strong emphasis around determining duration of therapy, which I think is a really critical point of discussion. So hopefully we get a chance to sort of talk about that in today's session. Okay, and I think finally for our last poll for the session, I think, before we sort of move on, which of the MEK inhibitor-related toxicities do you feel is the most difficult to manage? And again, please pick your most challenging one rather than all of these options. Okay, and I think unsurprisingly here, this is around managing dermatological toxicities in patients, which is obviously near universal when we're looking at using these agents in patients. So we'll be able to spend a bit of time on this later in today's session, and hopefully we get an opportunity to talk about some of these. And I was wrong, sorry, next question. What is the biggest challenge you face when transitioning paediatric patients with NF1 to adult care? Okay. Now, yeah, fantastic. And this is really pertinent to myself as an adult neuro-oncologist on the receiving end, a lot of these referrals as well. So we'll be talking about transition of patients and be really interested to hear from the experience of others in the room and online about things that have worked in your care. All right, and so with that, I want to hand off to Dr. Metrock to discuss the role of MEK inhibitor therapy.
Hi, everyone. Thank you for having us. Okay, so the role of MEK inhibitor therapy for these patients. Plexiform neurofibromas, as we know, are very challenging tumors. They can present anywhere in the body and can have any kind of effect on the surrounding nerves. And so every patient is their own unique case. Surgery does play an important management role in NF1-related plexiform neurofibroma, but there are many, many challenges. And if you read the literature on this, the numbers can be all over the place depending on what type of patient population was included. But in general, complication rates as high as 32% after surgery. They can actually have worsening sensory symptoms after surgical resection of these tumors, new or worsening motor deficits. If we're dealing with tumors that are abutting the spine, CSF leaks or pseudomeningoceles, spinal deformity, certainly wound infections, also bleeding risks, right? So 46% of patients that had tumor progression after surgery. We tell these patients, we're going to go in, we're going to take these tumors out, but nearly half of them, the tumor grows right back. And they're asking, why did we go through this? And 20% went to repeat surgeries. So what else can we do for them besides the operating room? That's where MEK inhibitors come into play. Our goals for MEK inhibitor is to disrupt the pathway, to disrupt what's making these tumors live and grow. So as we know, the pathway that is activated in NF is regulated by neurofibromin. So neurofibromin normally takes the GTP-bound RAS to GDP and makes it inactive, right? It's a stop sign. But when we have a dysfunctional neurofibromin, the pathway keeps moving forward. As you can see in the illustration here, goes through the MEK-ERK pathway to excessive cell growth. When we treat these tumors with MEK inhibitors, our goal is to put the stop sign back and hopefully reduce proliferation and survival of these tumor cells. In addition, right, like we love when we look at an MRI and we see tumor shrinkage. That's always rewarding for us and the patients too. But in addition, we want to see clinical benefit as well, improvements in pain, physical functioning, and quality of life. Here highlighted are 3 MEK inhibitors with approval. So selumetinib is approved by the FDA in the US, by the EMA and EU, the MHRA in the UK, TGA in Australia. Mirdametinib has approval in the US, the EU, and the UK. And then China has a drug called luvametinib approved. We now have had several clinical trials that have looked into evidence of benefit. So the SPRINT studies, or the pioneer studies that had 74 children with NF1-related plexiform neurofibroma, a 5-year treatment with 5 years of data from that. Overall, a response of 70%, with some durable PN shrinkage. However, those are patients that have stayed on the drug, right? Continued use of selumetinib demonstrates sustained improvements in pain and decreased use of pain medication. There's the clinical benefit that we talked about. And more recently, the SPRINKLE study has showed very similar results with a granule formulation to allow access for younger children that couldn't swallow the selumetinib tablets. And then over here you can see the benefit of the selumetinib versus the natural history study, which was with a comparator in those early trials. Mirdametinib in the RENEW study also showed similar benefits with confirmed overall response rate of 52% of patients with a best shrinkage of about median size of 42%. So some patients experienced up to 90% shrinkage. And that was, children and adults both had benefit there. With a deep response, so greater than 50% plexiform neurofibroma reduction in patients, in 15 of those patients, 52%. Again, with continued treatment, there was long-term follow-up that showed sustained improvement in pain and quality of life. The comparator graph on the side, again, also comparing to the natural history study. A few other targeted therapies that are in development that we wanted to highlight. Trametinib is another MEK inhibitor. The TRAM study, looking at children, also showed shrinkage of tumors. And the TENT study is a phase 2 study looking at children, teenagers, and young adults with plexiforms and OPGs. And then on the left side of the screen, you'll see the Helix 1502, which is a small molecule inhibitor. It's not a MEK inhibitor. It's currently in a clinical trial through the Neurofibromatosis Clinical Trials Consortium. The INSPIRE NF trial, it's a phase 2 study looking at an oral agent dosed 3 times a day in children and adults with NF1-related plexiforms. On the initial question slide, people were talking about one of the biggest challenges was when to treat. And I think that is a challenge, and it should be, because what I talked about at the beginning, right? All of these patients are their own person with their own tumor, and it's very specific location doing what it is doing in that phase of their life. So when do we treat? At the top, you'll see pediatric recommendations. On the bottom are more geared towards the adult recommendations. So we find an asymptomatic plexiform not near a vital structure. I've seen where some people want to jump to treat that, but that's not necessarily the best interest for that patient, right? It's okay to observe those patients. Continued surveillance imaging, continued close follow-up, make sure we don't start to run into problems. For asymptomatic tumors near a vital structure, this becomes a bit more difficult. There's particular risk of growth in these young patients, and so you're trying to anticipate, are they going to run into trouble with where this tumor is? And so it's okay to continue to observe very closely, maybe even more closely, or consider treatment. Certainly, if there's likely morbidity and growth, that next column, then you would want to strongly consider or recommend treatment for those children. Now, adolescents and adults, as the tumor is changing and progressing, you also need to have a high threshold for looking into if this is changing into a more malignant tumor, one of the atypical forms, or an MPNST. Pain. Do we treat for pain? So I think it is worth considering treatment. There are, like we showed in those trials, there have been benefit for some patients in pain. There are a few ways to manage the pain, and that becomes a discussion with the family on that evidence and where they are in their life with beginning treatment and side effects. Deformity. same. This may be a case where we consider surgery, but then there's also the question of what role do MEK inhibitors play with surgical resection, right? Is it worth trying the MEK inhibitor up front and then seeing how they do, move to surgery, try the MEK inhibitor to prevent growth, right? Or do you move straight to surgery and then add the MEK inhibitor on the backside of surgery to try to prevent growth? We don't have that data from clinical trials. I think it would be very difficult to do in a trial format, but it is definitely something that I've considered in my practice, and I know others have as well, with using them in combination. And organ compromise, again, this is the same story, different complication, right? If it's truly an organ compromise, what role does surgery play? And then how can we use a MEK inhibitor to best help that patient? And always consider whether or not it's changing into a more malignant form, which would need more aggressive treatment. All right.
Right.
Yep.
So we're going to pivot back here a little bit, so I can ask Katie a question to begin with, and then open to the audience for some feedback on experience. So this is a case, I think a pretty typical case seen in the clinic. David, who's 12 years old, was diagnosed with NF1 when he was 16 months old, has a plexiform neurofibroma involving the right hand, was diagnosed at age 5 and was previously asymptomatic. They've seen you in clinic and they've reported progressive growth over 12 months, causing intermittent pain, fine motor impairment and occasional fingertip numbness. So first question, Dr. Metrock, in your experience, would you consider to observe or monitor, or is it time to think about intervention here?
Yeah, so this is a 12-year-old who we've been, in my understanding of this vignette, that we've been monitoring this child for several years. They've had this plexiform on their hand, and now it's causing him new issues. It's growing in addition to pain, motor impairment, and an occasional fingertip numbness. So yes, obviously we would want to make sure we had very up-to-date imaging, but this is a case where I would strongly consider and recommend treatment. I think if you have a growing tumor that's causing new problems, and that this patient is one that very potentially could benefit from MEK inhibitor therapy.
Yeah, and just sort of moving forward on that, in your practice, what do you take into account from a patient factor and a tumour-specific factor to think about surgery or MEK inhibitor? You also talked about, or potentially the combination of both as part of a therapeutic plan.
So we haven't dived into this too much yet, but these patients really do need a multidisciplinary approach to their care. And so having a surgeon who we feel very comfortable with, their knowledge base and their experience with NF, I think is important in these cases. Yeah. Because potentially surgery could be an option, but hand tumors are tough, those nerves are tough, and the potential to leave that child with lifelong issues using his hand, I think, is high, depending on exactly which nerves it's pressing on. And so I would consult my surgeon, who I know very well and has done a lot of these, is taking care of a lot of these patients with me. And we would review the images together with our neuroradiologist and pay a lot of attention to that. But in general, from a hand tumor, those tend to be a little bit harder if they're deeper and are ones that are actually causing motor impairment already. So I would consider surgery, but this may be a case where I went straight to MEK inhibitor.
Yeah. And we're going to get into this a little bit later as well, but if you're going down that MEK inhibitor path, what are the baseline assessments that you think about conducting before commencing treatment?
Yeah, so we do, basically the ones that were recommended in the trials, right? We do lab work, CMP, CBC. We also grab a magnesium and phos level, just looking at from kidney function standpoint, CPK level at baseline. We'll do a urinalysis. We will also, if they're of childbearing age, do a pregnancy test and continue monitoring that throughout therapy. We will get a baseline EKG. We don't necessarily follow that moving forward, but we get a baseline and we get echocardiogram that we can continue monitoring forward. And then also a baseline ophthalmology exam. Whenever possible, I recommend from a pediatric side, a pediatric neuro-ophthalmologist. But we want to make sure we can get a very good baseline exam on these children so that we can keep that moving forward as they go through therapy.
Okay, great. So I'm going to move forward just off this question and we've got another polling question next before we move into the next part of the talk. And this is sort of hoping to sort of prime the later part of the session that we'll get to next and some of the education components. So coming back to this particular patient, if all options are available, which strategy would you pursue when managing a 12-year-old patient with NF1 and a symptomatic plexiform neurofibroma with the clinical history we've just provided? So based on Katie's experience, we're interested, maybe people have a different opinion or a different practice at their location. So please go ahead and answer these questions. Okay, all right, so we're changing a little bit here, but a lot of people thinking about both options, and I think that's really important because it suggests, as we've talked about, the need for multidisciplinary care and considering the right option for the right patient is really critical here. So I think that's a really key message that's coming through here. Okay, so moving on to the next part of the session was really thinking a bit more about MEK inhibitor treatment in patients with NF1, thinking about toxicity management in particular and that multidisciplinary care. And so to start with, this is, when we think about all of the different people who are involved in the care for patients with NF1, these are some of the groups who are involved. And I think when I reflect on this figure is that we acknowledge that different centres will have different availability of all of these specialties at different times, and you may have different groups who are more engaged within the NF service and other groups which you may find more challenging to engage. And I think we acknowledge that whilst there is a potential best practice or potential sort of perfect scenario that we would all love to have, then the reality of that in different care settings means that often different clinicians are doing different part of this work. But what this sort of graphic really indicates is that we need to think about proactive, active surveillance for patients who are receiving care for plexiform neurofibromas and thinking about it from these different perspectives in care. And so Dr. Metrock has already gone through the different agents that have been approved, and again, just a reminder that we acknowledge that this is an international audience, both in the room and online, and so just to acknowledge you'll need to follow your own reimbursement and practice guidelines. But this just highlights the current dosing and schedule for selumetinib and mirdametinib, acknowledging that one of these agents is given continuously, whereas mirdametinib given 3 weeks on, 1 week off. And one thing that we haven't indicated here, but certainly as a clinician, I'm sure many of you who also see adolescents and young adults, we haven't talked about adherence here as well. And I think providing this information and thinking about adherence to treatment being critical to achieving good outcomes is also, a really important message here. And so thinking about toxicity management, when we went through the polling earlier, the majority question came back as dermatological toxicity, and I think for those of you who are treating patients with MEK inhibitors would probably note that I think dermatological toxicity would be of varying grade would be nearly universal amongst our patients. But the message that certainly I try and give, and I think we're trying to give here, is that toxicity is typically predictable. Most of these toxicities can be managed well, particularly with proactive management rather than reactive management. But there is a few more significant toxicities, thinking about cardiac toxicity and ophthalmological toxicity, which are rare but potentially severe. And so we need to be educating our clinicians, our junior colleagues, but also patients and their families to be mindful of certain symptoms that they need to bring to attention urgently as well. And so you can see that slight difference between paediatric and adult patients, but I think most of these are fairly universal across children and adults. And so Dr. Metrock also gave you an overview of approach at their institution around baseline surveillance, and I'm not going to go through each of these. This information is here as a resource to think about screening and surveillance. But again, I think having a protocol and having a way that we look after all of these patients at baseline and then on treatment in a scheduled way ensures that we are identifying potential toxicities early. And again, as we sort of emphasised from the outset, thinking about proactive care rather than reactive or episodic care being really critical for how we manage patients on MEK inhibitor treatment. And particularly when thinking about dermatological toxicity, there is the idea of sort of universal baseline care, and I think skin hygiene and skin care prior to starting treatment, remains the critical advice before starting treatment in patients. And this is something that I think, we know leads to better outcomes. And certainly in my own practice, the patients where we don't do this well and come back with more severe early toxicity find that much harder to get on top of, rather than if we can, set up good skin hygiene, good skin care up front prior to starting treatment. Different proactive prevention strategies, whether you're in a paediatric and prepubescent setting or whether it's post-pubescent, the different approaches here are used in practice. And then obviously different reactive management for managing both dermatitis and acneiform rash. And I think the guidelines and the sort of message here again is that, clearly, if any of these symptoms become, more impactful for patients than mild to moderate, is early engagement with dermatology colleagues. And certainly in large institutions, I think our dermatologists are very familiar with getting on top of these early, and their involvement will also have a big impact on adherence to long-term treatment as well. And we're talking a bit about duration, and having good control of skin care is going to be critical for patients to want to continue taking these medications in the long term, and allowing them to therefore derive that clinical benefit from treatment is going to be really essential. And so the other sort of issue, I think, in terms of looking after patients on treatment is, how do you assess response? And all of the excellent clinical trials have typically used volumetric analyses as a primary or secondary radiological endpoint. But unfortunately, most of us don't have access to volumetric measurements, and we'll be typically using our standard 2D measurements to measure assessment of response to treatment. And that doesn't always correlate with a volumetric change. And so it can be quite difficult to then convert what's actually happening radiologically into the clinical space. And so I think that really emphasises the need to have patient-reported outcomes, or at least thinking about, even without a radiological change, has there been improvement in pain? Has there been any improvement in the cosmesis outcome, if that is relevant for patients? Has neurological function changed? I think using pain diaries, looking at the amount of analgesia that's being used, is a really critical tool in conjunction with the radiology. I often say that to our patients, we'd be really, thrilled if we see a marked shrinkage of the tumour, but we're also thinking about clinical benefit. And that's obviously critical when we're thinking about lifelong treatment for patients with NF1. Not necessarily lifelong treatment on MEK inhibitor, but thinking about lifelong care for patients with these conditions. And so, what does that sort of is a nice segue into thinking about transition of care, and this is something that we think about a lot in our practice, in how we can create the optimal transition pipeline. And this slide and the next slide is probably providing a wish list of what would be if we could have a perfect kind of transition scenario, which again we know are often limited by resources and practices and referral practices across institutions. But I think identifying that care is different in adult and paediatric setting, and having that crosstalk between those settings is really critical. Often, our patients will come across to the adult hospital, and they're used to having much more multidisciplinary care in a paediatric setting, often a little bit more coordinated and organised, and much more focused around caregiver-driven support. And that often leads to challenges in transition, where patients can be lost to follow-up during that critical time in their care, and we often assume that patients turn 18 and they're ready to have look after their own care themselves, and we need to have a much more family-involved approach to how we look after these patients in transition. And unfortunately, still in the adult setting, apart from some excellent specialised centres, we acknowledge that a lot of that care can be quite fragmented. I think patients highlight a lack of multidisciplinary care, and sometimes inconsistent follow-up. So that loss of structure and change and transition from adult to paediatric through that AYA is a high area of risk when we can lose patients to follow-up, where we may not get excellent adherence to their treatment so they get the best care, and I think something that we need to take into account early as part of transition. And so these are some of the things that you might want to think about in how you might support that transition to adult care. And it starts early. It's how do we start to encourage young people to participate in their own care? How do we start to give them a little bit of autonomy and start to think about that future planning? And that can sort of transition into self-management and readiness, which happens at different ages for different children. And so we can then have that sort of formal handoff into the adult setting that then sustains into long-term care in the adult practice. And, Dr. Metrock, obviously working at UAB, you work in a really, established NF1 centre across the paediatric and adult spectrum. How does this work in your centre, and have you got any guidelines or suggestions for the group?
Yeah, thank you. So this is something I have been passionate about, but I'll be honest, as I've started taking care of more and more of these patients over the years, have become even more passionate about getting them prepared for that transition. And it looks so different for each patient and family. I have some patients with NF1 who they hit 18, they're on their way to college, they're ready to manage their next steps in their care. And those are the ones that are a bit easier, right? You can send them along the way with their summary, their health summary, and they would be fine wherever they went. But there's a lot of patients that don't fit in that bubble. And so for those patients and their families, I like to start introducing the concept of one day you will go to the adult world very early, so that they recognize that they become very attached sometimes to their team, and it can be really traumatic for them to go. Not only their team, the buildings itself, right? In pediatrics, we have colors and it's a very inviting, warm environment, and it doesn't always feel that way in the adult world. When I first came to UAB 8 years ago, Dr. Bruce Korf was there, and he saw children and adults. So he was the bridge, and it was very much easier transition that I stepped into in managing patients. But now he's retired from patient care, and so we've had to sort of step back and say, what does it look like at our institution to get these kids to their next step as adults? And one of the things that we're working on right now, we have a new adult provider, Dr. Rebecca Brown. And so what we're working on, and this is just an idea, right? I think every place needs to look at the resources they have and what would fit with their practice and their people. But we actually are making a video where I go over to the adult side and I'm talking with her and showing her around and taking a tour through the clinic so that they can see that. And then they come to our clinic and they can scan a QR code and they can actually get into that and see the video of me, the person they know, and my nurse practitioner who they're very close with, walking in that space and talking with their new provider and seeing what that could look like. Then we also have some opportunities for Dr. Brown to come to our clinic. And we've really taken that model from our sickle cell team, where they have a transition clinic where they bring the adult team over for a few clinics in a row so that the families get used to seeing their new faces. And our goal is to really, and I'm hoping we can measure this, see how many more patients we can move to the adult world successfully that continue with a seamless transition into their adult care without missing a beat. So again, ideas, every place is going to be different with your people and your resources, but
yeah, I really like the video, and something that when I heard about was something I want to put in place in our setting, because it seems like a really simple kind of opportunity to engage and to upskill patients before they hand off. Okay, we're getting close to the end, but we want to come back to our case. Just this, our patient David, who after discussion with the clinical team started on a MEK inhibitor. And we might just go through these questions relatively quickly, Dr. Metrock, before we get to the polling questions. But how do you assess treatment response, and what do you think is a meaningful clinical response?
So both, we look radiographically, right? Are we getting change in the tumor? And then very important to have those baseline exams and expectations in place with the family of, okay, we're starting a MEK inhibitor therapy for what purpose? What are our goals? Pain? What is our quality of life? Do we have functional impairment? Are those things, from a pain and functionality standpoint, is that getting better? And what is your quality of life? And so I think looking at it across all of those different aspects is really important, because I have some patients where the tumor doesn't shrink, but they feel better, and that matters, right?
Yeah. And I think we covered some of these other two questions. So in the interest of time, just so we keep to our schedule, we might just sort of start to wrap up, and then if there's an opportunity for questions, we'll take them. And, this was the key outcomes we were hoping from today's short session we'd be able to achieve, and highlighting really the lifetime need for care and follow-up for patients with NF1. And, that requires this long-term proactive management, monitoring symptoms, progression, and thinking about that risk of malignant transformation always. Newer treatments are emerging that will vary from practice to practice, and so we need to consider about their availability as part of the care pipeline and the role of surgery and multidisciplinary care. Haven't been able to touch, so much on the future of NF1 care, but, I'm certainly excited by efforts happening internationally around how we might integrate biomarkers, both imaging and liquid biopsies, to think about how we can better monitor patients on treatment and identifying that risk of malignant transformation. We know that the field is emerging with novel inhibitors, which may have different safety profiles and activity profiles, and other chemotherapy-sparing approaches which might be relevant for this cohort. So, I think, as a clinician looking after these patients, I'm excited by the future of NF1 care, and I think the opportunities both in clinical practice but also in clinical and translational research, where we have an opportunity to improve outcomes for patients and their families. And so just to finish off with the last couple of questions, if you've got your device open again, would be really interested in your follow-up now and how prepared you are to manage MEK inhibitor-related adverse events. And really enjoying the music choices. Yeah. Okay, great. All right, and for those who are feeling less prepared, hopefully you can engage with us afterwards or online with some questions where we might be able to follow up and improve some of that feedback and follow up, but thank you. All right, the other critical issue was around how prepared you are to support transition of patients to the adult care and in collaboration with other partners. And I think, we acknowledge this is a big challenge in the field, and, there's lots of different solutions here. So hopefully you can connect with others and see what they're doing in the institutes and what's working well. And so just to wrap up, I'm going to take a seat, and we've probably got a few minutes to answer questions. Just encourage you, if you don't mind, just submitting them through the QR code. That will just help us engage with the online audience as well. And I'll take a seat and we'll see how we go. All right.
I don't see it.
Should we start with the top one? Maybe I can direct that one to you.
You can see it.
All right, sorry. I'm going to ask this question of Dr. Metrock. Is there any evidence of ongoing trials exploring MEK inhibitors for MPNST or as neoadjuvant therapies? There's quite a few questions around MPNST, I think.
Yeah, I think, thank you for the question. It's a good one. I would like to say I don't think we have data to support that, MEK inhibitor therapy prevents the formation of MPNST, first off. There are some trials that are looking at combination therapies that include MEK inhibitors, but not as a monotherapy.
Yeah, okay. I might take one just down to the fourth question here. What is the role of MEK inhibitors in treating adults with NF1-related tumours? So I think we're fortunate in the recent publication of the COMET study last year, which was a randomised study on the use of selumetinib in adults with NF1 associated with plexiform neurofibromas, published in The Lancet, which met its primary endpoint of improving a volumetric response, but also co-endpoints of improving pain for patients. So, that's shown that there is clinical evidence, or there is a clinical trial randomised evidence for the use of MEK inhibitors in adults as well. There's obviously other single-arm studies on use of other MEK inhibitor agents as well, indicating that clearly this is a cohort who also benefit from treatment as well.
Is hydrocortisone the only medication recommended to treat the rashes, even if not ideal for long-term use? No. So I think with MEK inhibitors, we sort of see two kinds of rashes, if you're going to simplify it maybe. In the younger kids, often it's more of a erythematous or sunburn type rash, and we can see that in older kids and adults. And then there's also the acneiform rash, right? So those are kind of two different beasts. The steroid ointments can be really effective in the erythematous rash. Sometimes if it's bad enough, we do need to interrupt therapy, get control of that, but restarting, we actually can see patients that do quite well. For the acneiform rash, things like doxycycline can also help, again, depending on where you are and availability and approval for those medicines. But, those are two rashes that need to be looked at a little bit differently.
Yeah. All right. Well, look, with that, we're going to have to close today's session. We're very happy to follow up with the peer review team and answer any of these follow-up questions and get back to the group. I hope you've enjoyed the interaction, and we'd be really grateful if you could commit the survey after this. And if you're interested in further activities, please register your interest with peer review. Thank you again. Hope you enjoy the rest of your time at ISPNO and in Sydney, and good afternoon.